Good morning, guys. Sorry it took us a minute to get the Teams versus Zoom set up, but we bless technology, and sometimes we bless out technology. So glad we're moving forward though. But particularly for overdose awareness day coming up next week. We know Recovery and Harm Reduction Month. We really have been revisiting with all of the community partners, ROSCs, and groups that we're working with, how really to focus on this harm reduction and really understanding now that you've had, and we've been talking about some of the ways to interact with clients therapy wise, treatments, behavioral therapies that can be helpful. It's always good to come home that all of this has to be on the touchstone and foundation of a good harm reduction foundation in the work that you're doing. So as you guys know, I always like for this to be interactive. So when you see something, say something, questions, dialogue, that's that way we can have a real good discussion on this really important topic. We're going to outline some of the history of why we have to really focus on harm reduction and say that the focus is harm reduction is because you're going to learn a little bit more about the history of how we even got to the stigma and sadly the racialization of substance use issues and how recognizing this is a chronic health model, so we need to treat it as such. And what are the things that we can do with the new SAMHSA guidelines that can really help us to focus on language, on assessment, and treatment from a harm reduction standpoint? We always talk about stigma. What do you guys, as you've been learning more in substance use, as you're interacting with clients, what are clients saying about shame and stigma these days? What are the words? What are the discussions you guys are having?
I know one of the big things was, just that, it kind of keeps people from sharing and opening up.
Exactly. And particularly for some groups where family secrets were part of the, oh, you keep that in the family. You quiet as it's kept. You'll hear some of these discussions and people, oh, well, no, that we had to keep that keep that on the down low. We don't say those things. And the thing is, all of those activities, all of those statements end up killing, unfortunately, and causing that same isolation, that separation from society, and the likelihood of sadly of an overdose death because people are using in isolation, they're living in isolation, and they're not connecting. So stigma, besides that mark of disgrace or infamy or shame on your reputation, stigma also isolates. Good point, Gloria. Anybody else that's hearing someone talk about stigma? Yeah,
I have a
Dan.
thing. I have a thing that's going on in my neighborhood.
Mhm.
There is a sober living house that just opened up a block away from me.
Okay.
I'm dealing with neighbors who are upset and who say things we don't like we don't want those people in our
Mhm.
neighborhood. We don't need that. So anyway, it's just a mess, and now there's going to be a hearing
Oh, goodness.
in the court thing, and I'm trying to figure out what to say and who to say it to because I think um that's fine. I'm a proponent of having
Mhm.
sober living houses, of doing stuff for people, giving housing for folks who can't quite get there, but trying to break through that stigma with my neighbors who are frightened and
Mhm.
I don't know, angry. I don't know exactly how to describe them, but
Yeah, it's really multifaceted because not only is it not in my backyard,
yeah,
you also know it's the defensiveness of this isn't happening here.
yeah.
And so when you think about listening to what they say, the projection part of Freud plus and the react, no, this can't be, oh wait, this actually is happening, but I've got to be in denial of it,
Yes,
you know.
yes.
And so it plays so sadly into everyone's emotions about stigma, shame, and their own substance use. We know
Mm.
that alcohol use increased 53% across the population during COVID. But the stigma, the shame, look at the commercials for alcohol, but you don't see commercials for heroin, you know? we know that more women are having issues with liver failure, kidney failure. But you'll see these spritzers and this because the stigma and the shame isn't there. But so with no, this isn't happening, but what's happening in your house? And why is there a bottle of wine? Everybody's buying these wine refrigerators that hold 30 bottles of wine. Mm. And so you see how rolled up into it becomes. But it's really so multifactorial. It's not only the people who are being stigmatized, they anticipate being stigmatized, they internalize, I don't deserve shame. They then experience discrimination, particularly in the healthcare encounter, but over in all populations. Not only then the sources, community, healthcare staff, structure, laws, or policies. You know, you can public drunk. Well, you don't get arrested for being public. You're out in public and your blood sugar is 500 degrees. You don't have public, diabetes arrest. All these types of negative attitudes and prejudices, and that feeds this lack of social participation, the isolation Gloria talked about, the increased morbidity and sadly mortality, poor quality of life or mental health care, but because they don't expect to be treated well, delays in care, and then their own internal shame may lead to poor treatment adherence. Well, I don't deserve to have this, or other issues may happen, so it makes it harder to get to counseling, building up their skills, learning information that can be more empowering for them. We see how stigma creates, sadly, that really poor cycle. And I sent you guys the slides for this earlier too, so you'll have that. But when we talk about substance use disorder in particular, who is the most likely, what do you think of what do you picture when you say, who's someone with a 2-year history of IV heroin use, and they have 3 children that are now in DCSF custody? Think about that picture while I reading that synopsis. It's okay to say, please be honest. Who do you picture and who does society picture as the person having that experience?
Unfortunately, I used to work at a residential facility that had DCFS wards, and the unfortunate reality of it is 90% of my clients were African American.
That's true in terms of the DCF piece, but what we know is the average more white women are DCSF involved than Blacks. More white women may have DCS over the United States have DCSF involvement than Blacks. The difficulty is who's using versus who's using is being policed. One thing we know in alcohol or in substance use in general, about 10 to 15% of whites, Blacks, and Latinos use substances. But who is policed for their use? So the perception becomes the people that are getting arrested for substance use, the people that may have DCSF involvement for substance use. Well, what's that population? There are more kids in DCSF custody or DCSF involvement that are white, but the custody and actually losing children may fall more preponderant, the larger percentage to Black people. So that's why if you're looking, all these children are now in DCSF custody, but how many cases are open? So losing custody of kids sadly has become a more racially based issue versus those who just have cases with DCSF. So the DCSF services may be more likely to be in white, but who's having custody removed might be sometimes a higher percentage of the Black population, based on Black people being 13% of the US population, white people being closer to 40% of the population in the US.
But is it a thing because we take care of our own, the African American will, the auntie, the granny will hurry up and take the children instead of calling, getting the authority involved?
Exactly. That helps frequently, but sadly with people moving and mobility, so that people are moving out of neighborhoods, people that maybe live, you think about your knit family of your grandparents' day. Your grandparents, all their brothers and sisters lived right around them in the same neighborhood. Now think about where your families may be. They may be in different cities, they may be in different states, or all the way across the country. That diffusion of that cohesive larger family unit also makes it harder to catch what's happening. If you have a son or daughter living downstate, or living out, oh, they're down in Dallas where the jobs were, then are you as able to kind of reach in and provide that safety net that the family used to do, say, in your grandmother's day? What they're noticing is as those demographics spread out and change geographically, being able to capture that larger family unit is a little bit harder to do.
Okay.
In the next case, a client with a chronic illness presents to the emergency department in a pain crisis because they're out of their pain medication. And, we may have had clients that, well, they went to the emergency department saying that they were out of pain medication. Not happening as much anymore because they know that that's clamped down. But what do we think of, or who do we see in that scenario?
More Caucasian Americans.
Yeah, more Caucasian Americans, also more elderly. The elderly and over 40, and that's why you will notice in our demographics that just came out for the Cook County area. I don't know if I've been looking for I was looking for the Rockford graphics if the county had put out the number of people who had passed in 2022 from overdose. But take a look at that 40 to 65 demographic. Those numbers, unfortunately, are also increasing every year for those who are having overdose deaths, because it's generally someone who had been out working. We know the tradition of what happens if someone may become addicted to an opioid. They may have had a physical injury, they were prescribed opioid medications, and then opioid prescribing started dropping, and they then may resort to heroin or street utilization of prescription pain medicine. And then last, an IV methamphetamine user that was just diagnosed with HIV. What does that person typically look like?
I
I'm
would
sorry?
say white male, maybe.
Mhm. There you go. The white male is the most likely. And our percentages of HIV diagnosis are continuing to increase in heterosexual, are persons that are reporting heterosexual relationships, whereas we used to think of HIV issues more particularly with persons who were LGBT community. That's also from men and women is increasing in year to year, because there also has a not in my backyard thought about that continued potential risk. So we already know all the stigmas, that it's a choice, that it's a moral failing. We know all the bad language. We've been working to improve that. But we don't always recognize that sometimes some of these language issues actually came from recognizing that there are facts on substance use issues, that it's among the most stigmatized condition in the US and sadly across the world. And that isolation that Gloria mentioned, that not in my backyard, that Ben mentioned, all of those continue to perpetuate these ongoing deaths, even though we're really trying to look at what we can do with finances, with resources, with peer support, with services. We're seeing the numbers still go up. And healthcare providers, sadly, are right at the heart of that, in treating patients with substance use disorders differently due to their own stigmas about whether it's actually a medical illness or a moral failing. And we'll talk about where that came about in just a minute too. So that people with substance use issues, they expect and they sadly then experience stigma and have poorer healthcare outcomes. The World Health Organization says of about 75% of health inequity from people who are doing well versus people who are suffering from the diagnoses, diseases, morbidity, or mortality is because of this unequal treatment that they're receiving in the healthcare domain, in that healthcare encounter. They're being labeled, they're being, treated unfairly, they're sadly being discriminated against, and it's leading to their poor health outcomes. So we know that we in healthcare and providing healthcare and substance use healthcare are at the heart of making a difference. But it didn't always start that way. many people have seen Benjamin Rush. When you think about Rush University, that's named after Benjamin Rush, one of the signers of the Constitution. I'm sorry, the Declaration of Independence. So way back in 1776, in the early 1800s, he was writing about alcohol and drug addiction being medical diseases that needed medical treatments. So, and he's considered the founder of the psychiatry as a medical issue. So way back then in the 1800s, we knew that alcohol use disorder, substance use disorder was a medical issue, and the medical profession needed to recognize it as a disease and to treat it as such. And they started doing that. They actually had morphine treatment doctors, just like we think of now as methadone maintenance programs. They had morphine maintenance programs for people who were addicted to opioids. But then what happened? You know, even back then over the counter, you could go and buy over the counter at your Walgreens. They're celebrating their 100-year anniversary. So you could go and buy cocaine tooth drops for your toothaches. You could buy Ms. Winslow's soothing syrup with the soothing medication of morphine in it. We all know Coca-Cola had cocaine in it. That's why yeah. Have a Coke and a smile. And then what I really like is one night cough syrup with alcohol, cannabis, chloroform, and morphine. If that couldn't cure you in one night, I didn't know what ailed you. All of these were available over the counter. But then what changed? We know in the early 1900s, we had freed Black men entering society, voting in policies and becoming part of the political discussion and starting to try to rise from their past enslaved status. We had immigration of Irish and Italians who frequently consumed alcohol as part of their recreational activities. We had immigration from Asians who were working on the railroads in the West, who used opium recreationally, and those coming from Mexico to work in the railroads and in agriculture, who used cannabis recreation. We sadly, once again, our US society sadly utilized those same laws from a racial basis in methods of controlling populations and sadly incarcerating populations. In 1914, they voted for the Harrison Narcotics Tax Act. So it limited who could get opioids. No more over-the-counter narcotics. Bye-bye Coca-Cola with the cocaine recipe. Other medications that were thought to be controlled. That's what started part of controlled substances. In 1919, Supreme Court cases that began to criminalize persons who used substances rather than treating them, and criminalize the doctors who were prescribing morphine for patients who were opioid addicted. So that between 1919, when the Supreme Court had their first case of opioid prescribing, 25,000 physicians were indicted for prescribing morphine to patients who had opioid use disorder rather than incarcerating them. So all the morphine maintenance clinics that were available at that time for persons with opioid use disorder were closed. And rather instead, they were referred for incarceration. So medical treatment for substance use disappeared, particularly for opioid use. Stigmatizing and criminalizing began. And sadly, it was based on those who were using or the perception of those who were using. And some of the same discriminatory factors in terms of race and ethnicity that have been part of our founding as in the US. And so then what happened? From the 20s through the 70s, you would see things in media, marijuana, shame, horror, and despair. These are all actual articles and pictorial media posts that were in magazines. Drinking leads to neglect of duty, moral degradation, and crime. So addiction was no longer a medical issue, a public health issue. It was a criminal justice issue. addiction was a moral failing, is the Mexican nation locoed or made crazy by a peculiar weed. And you saw these actual statements, these actual articles, and then the growth then came from a mutual admiration society of AA to overcome the moral failing that was alcohol addiction, or narcotic farms, or electroshock, and sadly, jail for those who may have had substance use disorders, with medication only being available for detox or on some detox spaces, and the other thought of, well, now it's time for you to bring it to bear. And you can hear in some of the early AA and abstinence league type statements, okay, well, now it's up to you. It's up to you to beat this. And so if you didn't beat it, it was some type of moral failing regarding your addiction. We started after around 1970 to move towards returning to science because once again, we knew all along that this was a medical issue. But sadly, in the Nixon era, the advent of methadone maintenance programs, that was part of and recognized by the government at that time as a method of, okay, we know that at that time heroin was mostly used, or the largest predominance of use was in urban African American enclaves. So how do we monitor that and how do we maintain that? And that's where sadly some of the laws of having to be there at 5 o'clock every take home law, those types of things started. And as we mentioned earlier, when we talk about substance use, let me get the little pen so I can show. Right here, the number of people using substances, the dark green are those that are Black, the light green are those that are white. The number of people using substances are actually selling substances is about the same. But then who's incarcerated? More likely Black, over twice as likely than white, for drug arrest, for state incarceration, or for federal incarceration, certainly more Blacks than whites. And then laws came about regarding types of substances. So cocaine is cocaine is cocaine, we know that. But in the 80s and 90s, laws were passed so that 1 teaspoon of cocaine, of crack cocaine, you would serve the same amount of time in jail as if you were in possession of 2.5 cups of powder cocaine. In 2010, President Obama lowered the federal ratio for your time served in jail so that now that 1 teaspoon of crack cocaine, you would serve the same amount of time as if you had a half a cup of powder cocaine. But that's still 18-1 because there was a recognition of who and what groups were more likely to use powder cocaine versus crack cocaine. And so sadly, these structural inequities in our society led to structural incarceration. And we saw that as a disparity of who was able to actually receive treatment. During this time, whites were less likely to be arrested for substance use, more likely to be referred for treatment for opioid use disorder. Blacks and Latinos more likely arrested and less likely to get treatment in jail. That's why we've been really fighting to work against this and change this inequity. We know that in the last 10 years, oh, sorry.
Excuse
Someone
me,
has a
Doc. I ain't mean to cut you off.
Go ahead.
I had a quick question about what we talking about. Is methadone is like a substitute drug that people could get addicted off of too?
That's a really good question. I have a slide a little bit later, but I'll answer it to you now, for you somewhat now. Methadone, we actually, it's not considered a equivalent or what we call a substitute. What we do know, and I'll show you in a slide, in about 2-3 slides, about what happens to our brain after someone begins to use opiates and they have the tolerance first of opiates, which means they have to take more to get the same feeling. And then they have withdrawal when they don't use, which means their brain actually has a chemical response that stimulates then they're needing to throw up, they may have diarrhea, they may get that crawly skin flesh where it feels like their skin is creepy crawly. They may have other types of symptoms, nausea, headache, diarrhea. So that's actually a medical response to not having opioids in your system. Methadone prevents that craving, so prevents that withdrawal response, and it also prevents the craving response. And the nice thing about methadone and another medication called buprenorphine or Suboxone is that if you take a substance or if you take an opioid on top of it after you have methadone in your system, it blocks the heroin or the drug that you might be taking from getting to your brain so that it decreases the likelihood that someone can overdose. So we don't think of it necessarily as you said, becoming addicted to the methadone. What methadone or buprenorphine does is it prevents you from going into withdrawal. It prevents the cravings that people have, and the cravings is unfortunately what might lead to, crime issues in terms of doing things to get substances, or the cravings that people may experience where it makes them harder to focus on their treatment or their therapy when all your brain is literally saying, I need this drug. And I'll show you more about that in just a second. Okay, Keenan? So then in the last 10 years, if you notice, from 2010, when heroin was more likely one of the opioids more likely involved in an overdose death. More recently, fentanyl and other synthetic opioids have become the more recent cause of an opioid death. And in 2022, for Cook County, 90% of the 2,000 opioid overdose deaths that happened in Cook County, fentanyl was in the person's system at the time of death, along with heroin or other opioids. Sadly, during the same time, this blue line was the number of opioid deaths for white people up until about 2016. If you notice now, this green line, which is the number of Blacks who may be overdosing, Native Americans is the green line, and this pink line that is now for 2022 higher than the Native American death line, both now Blacks and Native Americans are the most likely to die from opioid overdose deaths in the US. Sadly, when people play a factor, when persons come into the system, say the emergency room after they've been Narcan for an overdose, Blacks are less likely to be offered medications for assisted treatment, such as methadone or such as buprenorphine, than whites, even if they have private insurance. So here we see that sadly, of all the people that were seen, about 15% of whites were at least offered some type of treatment like methadone or buprenorphine. Less than 10% of Blacks. After they've had a prescription overdose, same thing. So even when you have insurance, when you come into the medical encounter, you may not be offered treatment to be able to prevent those cravings, to prevent going into withdrawal, and to prevent a subsequent overdose if you do use an opioid substance again. So we know that we're still having these issues of trying to have equitable care, because for all the progress, the Biden administration announced $30 million in grants in 2021 for harm reduction. There's still some pushback. Safer smoking supplies or safer smoking kits were rejected from that harm reduction tool. And so if we notice many times, what we encourage people, if they are using, to help toward moving towards recovery, hey, it's less likely for you to have an overdose death if you might smoke your drug versus inject your drug. So here's a safer way that you can't get HIV. Here's a safer supply. They're no longer able to offer those as part of a grant, because unfortunately it was turned into, well, now the Biden administration is giving people crack pipes. And when we think about crack pipes, remember that racialization of cocaine versus powder cocaine? Once again, we're talking about that same not in my backyard that Ben was mentioning. And unfortunately, there's a lot of emotion tied to that. It was just February of this year that the Biden administration lowered that 10-to-1 ratio of powder to crack cocaine federal sentencing to now 1-to-1. So if someone
Tanya, Richard can't hear you. I don't know what, he can't barely hear. He can't say anything.
okay, can you guys hear me okay? Let me turn the volume up. Can you hear me okay?
I can hear you, Dr. Sorrell.
Okay. Richard, I'm not sure what
I
may be.
can hear you, Dr. Sorrell.
Okay, Richard, I would suggest log in, log out, and try to log back in. See if your audio will improve. My volume is up at 100, so I can't turn my volume up any higher. Try increasing your volume, and then maybe try to log back in and see if it works. And see if
I've tried that several times.
Let me see if I can.
It may not be from your end. I can just about hear you if I hold the phone up to my ear, but I can't see the charts.
I'm trying to see if it'll type what I'm saying. And I don't see that. I don't see where I can do that.
Okay, don't worry about it. Go continue.
Sorry
We'll
about
have
that.
the playback as well available.
Okay.
That's fine. Thank you.
So it's just been this year that now if someone is arrested for crack cocaine or powder cocaine, they'll get the same potential sentence. So it's taken that long to get back to what Benjamin Rush had initially in terms of moving towards treating parity and equitably, but also moving towards treating this as a disease. So when we think about the substance use disease, what is the current definition? We know that it's a complex chronic disease of the brain, that pleasure and reward system. And Keenan, I'm going to get ready to show you more about that on motivation. So our brain learns that memory. Those of you who may be in recovery, you learn that memory, and you can even talk about it in your groups and share, yeah, I know how that felt, or when I was having that craving to feel a certain way. The motivation and the circuitry in the brain actually changes. So it's a chronic relapsing disease characterized by that compulsive seeking of the drug to reward your brain, because your brain is seeking that, and then despite the harmful consequences and changes that are continuing to occur in the brain. We're actually working now on a vaccine that could prevent that tolerance and dependence as part of the drug cycle and substance use disorder cycle. But we hope that in the future that for people, because as you know, when we talked about, wait a minute, Tanya said that in the 1600s and the 1700s, people were using substances because we've always had issues with trauma, emotional issues, emotional disorders, depression. And sadly, it's always, even back then in Benjamin Rush's time, been easier to get a hold of alcohol. They used to call it mead then instead of beer, but it's always been easier to get a hold of mead or morphine or alcohol or drug than counseling, therapy, and trauma-related care. And so when we talk about this opioid crisis, we've had waxes and wanes. We've had up and downs of people using opioids, morphine, other types of substances all through our history because we've all neglected, and sadly the US is somewhat neglected, treating mental health issues and mental health problems and providing the preventive care for trauma, stress, abuse that may happen in your upbringing, from becoming an adult problem that they may then use a substance for, because pain, emotional pain hurts just like physical pain. And until we treat emotional pain equitably, it will continue to cause these issues. And so it makes us ask the question, is relapse even the right word when we talk about someone resuming substance use? Because when we look at people relapsing from their blood pressure pills so that they have issues with hypertension again, or relapse from not taking their asthma medication, we actually see that more people have problems being adherent, we might call it. Are you compliant with their high blood pressure medication, their asthma medication, or their diabetes medication? It's not on the chart here, but it actually was over here too. Then once people get on substance use treatment, relapsing on a substance. Isn't that interesting? But think about it. Are you being prescribed a medication for a chronic medical issue, high blood pressure, asthma, or diabetes? Raise your hand if you're 100% compliant every day, taking your medication like you're supposed to, watching what you eat like you're supposed to, keeping your blood sugar under 100 when you take your blood check. Why is not everybody raising their hands? Keenan, you're on it?
Yeah.
All right,
Yeah.
you're the man. But look at all of the rest of us that are like, most of the. So is even calling relapse what we should do if this is truly a medical issue, when we already know that people with high blood pressure, diabetes, and asthma have higher relapse rates than people that have opioid use disorder and are on medication? So we know that diseases may vary from time with their stress. Then we may have ebbs and flows. We know that it's always a chronic process of working towards recovery. And we need to be using those same words and treating people the same way when we're treating them for their substance use and their hypertension as when they have asthma or diabetes. Make sense? And that's where we're realizing that we need to work towards. And then just like Keenan asked us, he's Johnny on the spot. He's going to be our role model for good adherence. Why do some people develop a substance use disorder? And why is it so hard to break those chains? We know that biology plays a lot to do with it. So if someone has a family history of genetic of substance use issues, we know that for men, they're more likely to have substance use issues, or if you have a history of a mental health issue, we know that that plays a role. We know that environment and those early childhood issues, a chaotic home, parents' use and parents' attitudes towards use may have a role. Also, peer influence. So, and then the community. So we know environmental factors play a role. The age that people may start using. Most people who have a substance use problem start to use a substance between the ages of 10 and 14. Yes, I said that right. 10 and 14, middle school, because the trauma, the issues, the biological predisposition, and issues in trauma and upbringing are right there with the stress of now social pressure in middle school. And if we're not providing care, coping skills, trauma-informed care and services, once again, it's easier to get a hold of alcohol or drug than to get a hold of a therapist or counseling. And that's where the brain mechanisms changed towards addiction. In craving, and people, well, I can cut the cravings, I can ignore the cravings. Cravings for food, if you haven't eaten all day and you know how your stomach will remind you in the evening that you haven't eaten around 2 if you missed breakfast or lunch. Craving for food sends out chemical signals to the brain that are about the size of a baseball. Cravings for water, the most biological need for our body is water, will send out signals in your brain that would basically fill chemical wise about the size of a basketball relatively. Cravings for drugs fill the chemical urge of the size of a baseball field. So when we tell people that they're we got to ignore those cravings, that's your brain sending the chemical equivalent of a baseball field stating of wanting to use, which is why cutting and addressing craving has been so important for the medication and Suboxone, because sadly, it's what really leads to continued use of a substance. Questions, guys? I know, Keenan, this was a question you were asking about.
Yes.
Any other questions?
No, ma'am.
Okay.
That's crazy. I'm just looking at these cravings.
It's phenomenal. They've actually studied this. The craving to use, yes, the size of a baseball field. So even knowing back then that Benjamin Rush, folks in the 1800s knew that those small doses, at that time they used morphine. Now we're using something that isn't gonna, as you said, cause that risk, increase that risk of overdose, or cause that pleasurable sensation about that reward center, like methadone or buprenorphine. But it cuts the cravings so that it tames those cravings, that baseball field cravings, down to size. it decreases the it cuts the withdrawal symptoms so that your body isn't going into that shocking withdrawal. And it also, if you do, as they say, relapse and use heroin or Percocet or OxyContin on top of buprenorphine, it blocks those brain receptors so that the heroin can't get to the brain. And that decreases that risk of overdose, which is.
They adding fentanyl to it now to boost it up.
The reason that they're adding the drug fentanyl to the drug supply, that
Yeah.
well, if someone is taking methadone or buprenorphine, the fentanyl still can't get to their brain because it
Okay.
blocks those brain receptors. Sadly,
Okay.
the reason that there's fentanyl in the drug supply is because it's cheaper to manufacture than heroin. Heroin comes from a poppy in Afghanistan. And think about trying to fly something that's made in Afghanistan all the way over to Mexico, or flying it. And there are two different ways that our drug supplies come to us. Uh, they're frequently flown into Mexico, and drug cartels that are in Mexico and the United States bring it across the border from American citizens, from U.S. citizens who put it in their cars and drive it across the border checkpoints. The other second way, that's the most common way, is to just fly it in from the U.S. mail service. So the U.S. mail service frequently catches a number of shipments. If you think about, there was recently even a shipment here. The person that they arrested that had fentanyl here, they were flying it in U.S. mail service from San Diego to Chicago. And what happened was wow, there's a lot of packages going from this one address in San Diego to this one address in Chicago. The DEA got a wind of it and started tracking that, and that's how they caught that fellow that basically he had enough fentanyl, they said, to kill over 100,000 people in his possession. But they were shipping it by U.S. mail. The Coast Guard does a pretty good job of catching any boats that are trying to bring substances in by boat. So it usually comes in by car from Mexico, driven by U.S. citizens. It's not driven by Mexicans because they were more likely to be stopped, but driven by U.S. citizens across the border are shipped in packages. Did that answer your question? And then we talked about those social determinants of health that are so important to be addressing. Do you have a safe place to play? Are you living in an area where it's hard to go outside because you might be a victim of crime? Do you have those types of services where you can have educational access? All of those issues, we sadly know, increase the likelihood that you may experience issues that may increase your stress, your trauma, and that may make it more likely for you to use the substance. And we know that those social determinants of health and stigma really impact substance use issues. On the individual, we know if there are no providers in a low-income area, then patients may not have access to Suboxone or medications to help stop opioid use disorder. They may not know what harm reduction is. When we go out into the community and are handing out Narcan, every time we go out, I have people ask me, what is this? I've never heard of Narcan. Oh, wow, I wish I knew about this for a cousin that I lost 6 months ago. Interpersonally, we still are sometimes in the tough love mentality. Well, we need to shun them. They need to go away. But that unfortunately only isolates folks, just as Gloria was saying earlier. And all of us learn CPR every year for our work, but we don't always know that we should carry naloxone so that we can have and help somebody that may need that. In our community, just like Ben was talking about, the Not in My Backyard, about substance use facilities, shelters, or recovery housing. Ben, I didn't even know you were going to mention that. And that's right there as a community issue that still makes it hard. And rural communities tend to, unfortunately, decline substance use services because they say that this thing isn't going on, although a grandchild can be right in the barn using substances. And then society, we've been working towards overdose prevention sites. And we had there's a bill right now in Congress last year that was trying to prevent harm reduction services and grants. And thankfully that didn't go through. So we're always working back and forth to try to address not only the social determinants of health, but also the stigma issues. So what can you do? And this is an important part, particularly for harm reduction and stigma about drug use or treatment. First, we have to watch our language. Because unfortunately, calling someone an addict, or even someone calling themselves an addict or a junkie, has become part of the stigma and shame of substance use, we want to remove the issue from the person. They're a person with an opioid use disorder. There's so much more than just someone who uses a substance. We want to recognize that this is a disease, and that a person living in recovery is ongoing in recovery, just like someone who's in recovery from diabetes or hypertension or asthma. And then we want to not use those words that connotate being dirty or clean your UA. It's positive, it's negative for a substance, because no person is dirty. And we want to also recognize that methadone and Suboxone not only help with decreasing cravings, they block and decrease the risk of overdose. So we don't want to say, "Oh, I'm on a replacement," or I'm using a crutch to get clean," because that unfortunately, is insulin a crutch? Do we call a blood pressure pill, or if someone's taking their asthma inhaler, is that their crutch so that they can breathe? So we know that medications that can help people to improve and get better, we don't want to label them as leaning on something, just like we wouldn't label someone who has diabetes on leaning on insulin for their life. We want to continue to work with meeting people where they're at, and communicating with them from where they are and how things can improve for them, to make sure that things are going well with them, and that we can work together to help where they are and help them identify where they want to go in their treatment, the changes that they want to make, and how we have resources and support and encouragement in helping them to get there. We want to work on developing that change language for behavior. We talked about meeting someone with their stages of change. And are there any questions, guys? Because there's someone knocking at my door. I need to go quiet and catch that right quick. Gloria, can you check if there's any questions?
Okay,
And I'll
no
be right
problem.
back.
Does anyone have any questions at this time concerning the PowerPoint presentation, harm reduction or stigma? Or anyone want to add to the discussion at this time? Ben?
I always have something to say.
Mhm.
Well, I'm a person with lived experience, as you all know. I'm in recovery for quite some time, and I listen to a lot of these sort of things, these sort of presentations, and I'm curious about the place that spiritual life and a spiritual experience has in the world of not just recovering, but of reducing stigma. I don't know. I'm not sure what I'm asking, but I mean, as I think of myself as a recovering person, like the biggest thing that I hooked into was gaining a spiritual life. And I know often doctors and researchers and stuff, it's a kind of not a thing that can be measured and is often not spoken of. I don't know, Dr. Sorrell, if you caught any of what I said.
I always want to recognize that that's part of meeting someone where they're at. If they have a spiritual background and foundation, then I want to include that in their treatment. I think when we look at spirituality in particular, and I'll ask, and as part of my assessments, hey, is there a spiritual foundation, a church or religion that you feel is important to you, that you want to be part of your treatment? That I'm acknowledging that for each person, because there actually has been studies that have shown that people praying for someone, I don't know if you guys saw that, I'll have to look that up and send it to you. People praying for someone, even if the person didn't know that they were praying for them, actually may have improved their outcome versus the control patients that didn't have someone specifically praying for them. So I'm not discounting anything. And if it's something that a client wants to have as part of their treatment, then I certainly want to look at it.
Yeah, and like I said, as a crabby old 12-step guy, I went into these programs
Mm-hmm.
not having anything and not wanting anything like that. It was aversive to me. So it was just, I don't know, speaking just personally, that getting some sort of introduction into that, or an idea of what that might be, as part of I know that's kind of a sensitive area, and as a doctor or a clinician, it's not like, let's hold hands and pray now, but I needed to be introduced to that, and it wasn't something that if you had interviewed me 20 years ago, I'd have said, no, thank you.
And sadly, and this is literally up my research alley of cultural-based care, but I think in trying to be a scientific body, medicine can't discount the spiritual realm. I mean, but think about it, they're not. What hospital have you gone into that doesn't have a chapel?
Mm-hmm. Mm-hmm.
So I think how they may include that, because it's hard to quote unquote study from a scientific vantage point, but people are actually trying to do that, just like that article that I mentioned. I'll make sure to post that to Gloria so she can send that out to everybody. But and when people know and meet with me, I readily tell them, when I know that spirituality is, well, hey, I pray for my patients. I pray for me to know what I need to do for my patients. I also realize that, one of Jesus's disciples Luke was a physician. So it should go on both sides. We have a program now called Faith in Recovery that we're lining up as one of the presentations for you guys. And it's actually, many states have started this initiative of helping churches know that that from that kind of abstinence mentality, or the get thee from me, that Satan, and sometimes that was part of our church's mentality, is that now, wait, we're leaving the 99 to go and get that one. If that one is someone that's using, then that's what Jesus is telling us to go and do, right? Where would Jesus be in this day and time? Would he be in a church, or would he be, on corners talking to people who are suffering and struggling? And so Faith in Recovery is a program that really is hoping to reconnect churches to the harm reduction needs of their congregations who may be struggling with substance use issues. And so I think that's another rebirth or reconnecting. Like if Benjamin Rush was treating issues medically, and now we're trying to come back to treating issues medically. At one time, the church was part of helping people with substance use issues, with alcohol issues or opioid issues. Now they're reconnecting to say, oh, well, we need to go and feed the flock.
Mm-hmm.
Those that are suffering. And I'll look forward to being able to present that the Faith and Recovery program to you guys too.
Oh, that would be so fantastic, Dr. Sorrell.
Oh, no worries, no worries. So, and knowing when someone needs help and knowing how to be able to get someone help is going to be one of the most harm reduction activities you can do in working towards getting them help. In particular with this fentanyl age, we saw from those statistics from 2016 now today, we've had percentages and increase every year in the amount of fentanyl that is in our drug supply. For the Cook County, for the Winnebago County area, fentanyl is now what we consider, almost 100% saturated. 90% of the deaths in Cook County last year, the persons had fentanyl in their system. I'm sure the Winnebago County stats was fairly the same, because we're basically getting the same drug supply comes to Rockford as what comes up to Chicago. So fentanyl's 50 times stronger than heroin. And so those numbers you heard me mention earlier, from the 40 to 65 year of persons overdosing, if I've been a substance user for 10, 15 years and I know how to mix my heroin so I don't overdose, they don't know now that fentanyl is in their drug supply, and so they may unfortunately overdose. So that's one of the things that we work on, and never using alone. There are programs. There's actually a website that will talk with you, will sit with you while you use if you're by yourself, because sadly, using alone and not having Narcan available can kill you. And sadly, there have been myths about this now too that may unfortunately further stigmatize people. You can't overdose from touching someone who may have fentanyl in your system. You can't overdose from fentanyl being in the air. There were a number of police reports where police were handling people and apparently it got on them and they may have overdosed. Sadly, that's anxiety. Um, Doctors, pharmacists, nurses work with fentanyl every day in hospitals. Nobody's falling out or passing out and or overdosing there, gloves or no gloves. It doesn't work like that. It has to be in some way ingested nasally, IV, or some type of way. It can't, you can't be by someone that's using fentanyl and then overdose from fentanyl because you're standing next to them or you're giving them Narcan. And sadly, what it's worried people about is that people won't feel comfortable helping someone who's overdosed. But well, if I try to give them that Narcan in their nose, I might get fentanyl on me and overdose and die myself. That isn't actually true. It doesn't happen. So we can try to help discount those myths because those myths are sadly contributing to shame and stigma and keeping people from helping. We all know how to give and use naloxone. This is just a reminder on how to do that. And hopefully we're all using the Illinois helpline, the Mar Now line for services and knowing that help is available. I'll make sure that you guys have these links too to be able to refer folks. And then finally, the newest piece in harm reduction and knowing that we use harm reduction in lots of things. If everybody was out on the air show this weekend or out at the beach, we put on sunscreen because we know the harms of prolonged exposure to the sun. We get on our car, we put on our seatbelts. And we knew that there was pushback. Most of you guys weren't born when seatbelts started to be used in the 70s, but people were upset because the government was asking people to put on a seatbelt when they get in the car, just like a helmet on a motorcycle. We have speed limits because we don't want to take hairpin turns going 80 miles an hour, or birth control when someone doesn't want to become pregnant. So harm reduction is just the focus of preventing harm and preventing death while someone is using a substance. And SAMHSA has just released their harm reduction guidelines, and it really is focusing on a number of ways that we can do things safer to keep people alive while we reach out to them and letting them know, educating them about Narcan, educating them about treatment, medications like methadone or buprenorphine, and educating them on recovery. Did you guys see the new harm reduction guidelines? And I'll post that in that link as well for you too. Did you guys see when that came out just a month or so ago?
I don't think I saw it. If you can give me the link, that'd be great.
I will certainly do that. I'll go over the main practices, and these are what they're recommending. Safer practices, so education and support on how to reduce risk for someone who is using, and providing them with risk reduction supplies and materials. We mentioned earlier when we provide safe syringes, then people don't get HIV, they don't get hepatitis C. And syringe service programs or needle exchange programs are a very important part of that. We should give out safer smoking supplies, such as alcohol swabs, smoking kits, because if someone is using IV substance, that's a higher risk of overdose than if someone is smoking their heroin supply. They're more likely to overdose and die if they're using IV than if they're smoking heroin or smoking smashed or liquefied Percocet or Oxycontin. We should have overdose education and not naloxone distribution. We should have fentanyl test strips. There now are xylazine test strips, so you can test to see if your drugs have xylazine, which is a horse or veterinary sedative that can unfortunately make it easier for you to fall asleep or overdose while you're using heroin or other drugs. We should also educate and integrate reproductive health so that women who may be using substances, men who are using substances, are using condoms, those same harm reduction for safer sex and other supplies as well too. And sadly, on the right, you see our map of the U.S. The states that are listed in orange have laws on their books that forbid them from providing syringe access, and we need to change that. This map came out in 2021. They've already reversed syringe service programs in Florida, Georgia, and Idaho. But still, all the rest of the Midwest and much of the South prevent these same harm reduction activities such as syringe service programs. Another harm reduction guideline is safer settings, just like you guys. Put in that plug for NERCO there. Day centers, safe spaces and environments so that people who are in recovery can live, find respite, learn to practice safer use, and receive support that's trauma-informed and stigma-free. Remember, we talked about that trauma, that stigma, that shame that leads to relapse. So day centers, special social spaces that offer harm reduction, that are low barrier, that are led by the community that they serve, just like you guys, access to safe and secure housing, and public health programs that are alternative to arrest in the judicial system are part of the next safer settings for practices for harm reduction. Safer transitions to care, making it easier for people to get care, harm reduction informed and trauma informed care. So health hubs and mobile clinics for persons who use drugs with that integrates HIV, hepatitis, and other healthcare services. Expanding telehealth like the MarNow program. There's the number there, and MarNow started out last year just in the Cook County area. Now it's all across the state of Illinois. They can talk, if someone wants help, they can talk with someone, have a Zoom or an appointment by video and be able to get started on buprenorphine to cut those cravings, to prevent overdose, and to prevent them from going into withdrawal that same day. This is one of the few states that has this program. When I was in Colorado, we were developing this program, so we have one there now too. This is a great program for help. A warm handoff for emergency departments with low threshold for medications for opioid use disorder initiation and post-overdose services. And we're working now to help emergency departments. If someone's come in and they've been Narcan, they can actually start buprenorphine right there. Many people know that Prince died from an overdose. Not everybody knows that 4 days before he died, he was seen in an emergency department and Narcan here in Illinois. If we could have started Suboxone or buprenorphine on him right then and there, he could still be with us making music, just like so many other family, cousins, brothers, and friends in our lives. And medication access and treatment on demand so that abstinence doesn't become the norm. Harm reduction and recovery, just like for hypertension, diabetes, is an ongoing recovery process. We don't stop someone's insulin if they miss and start eating poorly again or stop exercising. We need to do the same thing for these types of treatments. Safer access to healthcare with low barrier, ensuring that we have person-centered and non-stigmatizing healthcare that's trauma-informed with medications that are FDA approved. That first map that you see there, that's a map of all the methadone treatment centers in the US. And the blue color is where there is a methadone treatment. All that gray, unfortunately, is where people don't have access to methadone services to prevent overdose, to prevent cravings, and to prevent withdrawal. We also need healthcare settings that can be mobile, like the COIT van that comes out to Rockford, that can help start people on substances that are non-punitive, that can offer good standard of care in a non-stigmatizing, non-judgmental way, and that can offer mobile buprenorphine services like the COIT project there that Jordan Vold does in Rockford that can help people have access to buprenorphine care. Do you guys know how to get a hold of Jordan's program at COIT?
Can you repeat that, Dr. Sorrell?
Jordan runs the COIT program that's in Rockford. Do you guys know how to get a hold of him to refer clients to him?
I would have to ask Eric.
Okay, I'll make sure you have that email too. I talk with Jordan and Pastor Violet that's out there in Rockford all the time about increasing access to buprenorphine up there.
Yes, you're going to send that to me. That'd be great.
We'll do. And then the workforce, that's you guys. Sustaining the workforce that knows skills, that helps to manage workforce, and it can help with going out and meeting with people with lived experience so that you're part of this, and that peer support pays living wages, pays for essential benefits so that it isn't considered, oh, well, you're lucky to have a job. And sadly, has been part of some of the mentality initially for peer support. No, you are a valued person in part of this recovery process, and that wellness services and support should be done for harm reduction staff and volunteers, and training and technical assistance like I'm doing today to make sure that you're up to date on the newest guidelines. And then lastly, building the infrastructure. We need to hire more people that are persons with a history of substance use to help inform the policy of the agencies that serve. You know, nothing about us without us is what is the actual mandate from the Illinois Harm Reduction and Recovery Center Coalition, so that we can build on revitalizing our communities, that people that are at the community level lead in that discussion, and we really have a promotion of education on the value of harm reduction. So these are the guidelines that SAMHSA just put out, and so I'll be happy to make sure you guys have a copy of that. So in conclusion, we know that substance use is a disease. We need to treat it as a disease, that recovery is possible, and that recovery from substance use has higher percentages of success than recovery from diabetes, asthma, and hypertension. So why aren't we doing it? We got to get rid of these implicit biases. We've got to get rid of this stigma and shame. And sadly, we still have to get rid of discrimination, which we're working on across all areas of healthcare. We want to watch how we choose our words and avoid these labels that unfortunately perpetuate that stigma and shame, and educate others to be supportive, work against the negative attitudes that society may have, and make sure that we're treating people with a substance use disorder with dignity and respect, just like we would treat any medical issue. Any questions, guys?
No questions.
No, but I'd like to meet with you if you want, if you have a few moments to stay on the call.
I sure do. Why don't you go ahead and stop the